So this is the PowerPoint on anxiety disorders. There is a lot of information in this PowerPoint because there are a lot of anxiety disorders in the DSM-5. So I'm going to go through everything, and any questions that you have, we'll talk about them in class. So the first thing I wanted to talk about is what is fear. So there's that lady, and she looks like she's super afraid of something. And what she's super afraid of, it looks like an axe maybe. So that axe or machete, whatever it is, would be an immediate threat that she is afraid of. And what happens when there's an immediate threat in front of you is that you feel fear. So fear is an emergency defense system, fight or flight response. So I'm either going to stay here and I'm going to fight this axe, or I'm going to run away from it. It's an instantaneous response to danger. So what is anxiety then? So anxiety is concerned with possible uncontrollable future threat, not actually the present threat. And anxiety gives us all different kinds of feelings. It makes us feel helpless. It makes us feel like we're always anticipating that something bad is going to happen. We could have negative affect, so always anticipating that something bad might make us look irritable or grumpy or tired, like I don't want to deal with this, I'm going to go to sleep. Somatic symptoms, so like my stomach hurts or my head hurts or I have muscle aches, which promote the physiological readiness for danger. And then hypervigilance, like something is going to happen. I know, I'm watching all the time that something is going to happen. And anxiety brings upon these maladaptive coping patterns that can make things worse. So I know that there is a threat in the future, that something bad is going to happen, and I'm going to worry and worry and worry about it all the time. Or I'm going to totally avoid it, and then that makes the anxiety worse. So here is a little chart on fear versus anxiety. So fear is phasic. It's a proximal threat. Something is coming right now. It activates the amygdala in your brain, so the flight or fight response comes from the amygdala. There's a predictable cue, so something happens, I am afraid. There are thoughts of the imminent threat. Something's coming right at me, I'm afraid. Sympathetic arousal, so the sympathetic nervous system is aroused, and you want to escape. You want to get the heck out of there. Anxiety is sustained. It can be, it's there over a long period of time. The threat is distal, or it might not even happen at all. So it's way in the future, or it might not even be happening at all. It's really worry about this threat. With anxiety, the hippocampus and the amygdala are both activated. There's an unpredictable cue, so you don't know when this threat is going to occur. Like we said, thoughts of future threat. This causes muscle tension and avoidance. So I feel really anxious about something happening, so I'm going to avoid it at all costs. So in the DSM-5, there are a lot of anxiety disorders. There's separation anxiety disorder and selective mutism, which are both childhood disorders. There's specific phobia, social anxiety disorder, panic disorder, agoraphobia, and generalized anxiety disorder. And we're going to go through the DSM criterion for each one of them and the epidemiology for each one of them as well. So here is separation anxiety disorder. Here's the DSM-5 diagnostic criteria. So developmentally inappropriate, this is very important, that it's inappropriate developmentally, and excessive fear or anxiety concerning separation from those to whom the individual is attached by evidence of at least 3 of the following. So you have to have 3 of the following symptoms. So recurrent excessive distress when anticipating or experiencing separation from home or a major attachment figure. And this major attachment figure, it doesn't have to be mom or dad. It could be grandma, it could be grandpa, it could be a guardian. It's anybody that that individual has an attachment relationship with. Persistent and excessive worry about losing the major attachment figure, or something is going to happen to them. They're going to get sick. They're going to get hurt. There's going to be a huge disaster. They're going to die. If I'm not with them all the time, then something terrible is going to happen to them. Persistent and excessive worry about experiencing an untoward event that causes separation from a major attachment figure. So that means being kidnapped, being abducted, a terrible event that causes separation. Persistent reluctance or refusal to go out, away from home, to school, to work, anywhere where that attachment figure is not going to be, you are not going. Persistent or excessive fear of or reluctance about being alone or without the major attachment figure at home or in other settings. Refusal to sleep away from home or to go to sleep without being near a major attachment figure. And remember that it has to be developmentally inappropriate. So for 2, 3, 4, 5-year-olds to not want to sleep away from their parents or not want to sleep away from home might be developmentally appropriate. So age is really going to have a determination on this. Repeated nightmares involving the theme of separation. So you can get clients that constantly have dreams that mommy died or daddy died, or grandma went away, I never saw her again. Repeated complaints of physical symptoms when separation from major attachment figures occurs or is anticipated. You can see this when kids go to school and they feel sick and they don't want to go to school. And those are the physical complaints. The fear, anxiety, or avoidance is persistent. It has to last at least 4 weeks, so there's your duration in children and adolescents, and then 6 months or more in adults. And, of course, it causes significant distress, impairment in social, academic, occupational, or other areas of functioning. And then it's not better explained by another mental disorder, such as refusing to leave home because of excessive resistance to change in autism spectrum disorder. So really differentiating between, is this separation anxiety disorder or is this a symptom of autism? Delusions or hallucinations concerning separation and psychotic disorders. So is the client presenting as psychotic? That would be where your mental status exam would come in handy. Refusal to go outside without a trusted companion in agoraphobia. So we're going to talk about agoraphobia later down in the slideshow, but that literally translates to fear of the marketplace, so fear of leaving your home. Worries about ill health or other harm befalling significant others and generalized anxiety disorder. Again, we're going to talk about generalized anxiety disorder. So really being able to tease out as what you're seeing, is it separation anxiety disorder or is it generalized anxiety disorder? Or concerns about having an illness and illness anxiety disorder. So when separated from major attachment figures, children with separation anxiety may exhibit social withdrawal, apathy, sadness, or difficulty concentrating on work and play. And sometimes kids might fear animals or monsters, the dark, burglars, kidnappers, car accidents, plane travel, and any other situations that are perceived as presenting danger to the family or themselves. And remember, it's developmentally inappropriate and excessive. In my experience, most kids are afraid of the dark, but if you're afraid of the dark to the degree where you cannot even go into the dark without your caregiver, then that might be something to look at. Social anxiety may lead to school refusal. When extremely upset at the prospect of separating, children may show anger or occasionally aggression towards someone who is forcing the separation. I have a great story to tell you guys in class that pertains to this. I had a student with separation anxiety, so I'm going to save that story to class, but that's exactly what happened. Children with separation anxiety may be described as demanding, intrusive, and in need of constant attention. And adults may be described as dependent or overly protective. So here's the epidemiology of separation anxiety disorder. The prevalence is 0.9% to 1.9% among adults, so very, very rare. 4% in children, and 1.6% in adolescents. Most prevalent anxiety disorders occur in children that are younger than 12 years old. And then in clinical samples, males were equal to females in terms of having anxiety disorder, but in community samples, it was more frequent in females. So selective mutism. The DSM-5 diagnostic criteria for selective mutism: consistent failure to speak in specific situations in which there is an expectation for speaking despite speaking in other situations. So these are kids that maybe talk at home but won't talk in school, or vice versa. The disturbance interferes with educational or occupational achievement or with social communication. The duration of the disturbance is at least 1 month, and it's not limited to the first month of school. Typically, kids, especially kindergartners, are very, very nervous the first month of school, so you want to be very careful not to give a little kid that's going into school the first time the diagnosis of selective mutism. The failure to speak is not attributable to a lack of knowledge of or comfort with the spoken language required in the social situation. So the child definitely speaks the language, knows how to speak the language, but just is refusing to speak it. And it is not better explained by a communication disorder and does not occur exclusively during the course of autism spectrum disorder, schizophrenia, or another psychotic disorder. Associated features of selective mutism may include excessive shyness, fear of social embarrassment, social isolation and withdrawal, clinging, compulsive traits, negativism, temper tantrums, or mild oppositional behavior. It's important to remember that children with selective mutism have normal language skills. However, occasionally there may be an associated communication disorder. And so children with selective mutism are almost always given a diagnosis of another anxiety disorder as well. Here's the epidemiology of selective mutism. So the prevalence, it's a very rare disorder, again, 0.03% to 1% depending on the setting. So that's looking at school versus home versus in social situations. It does not seem to vary by sex or race or ethnicity, so it's pretty equal. It's more likely to manifest in young children than adolescents and adults. The onset is typically before the age of 5, and the longitudinal course of the disorder is unknown. So there's not a ton of research on selective mutism, and it typically clears up as as kids get treatment and they move towards adolescence. Specific phobia, DSM-5 criteria. So a specific phobia is a marked fear or anxiety about a specific object or situation. The phobic object or situation almost always provokes immediate fear or anxiety. The phobic object is situation is actively avoided or endured with intense fear and anxiety. The fear or anxiety is out of proportion to the actual danger posed by the object. And the fear, anxiety, and avoidance is persistent, typically lasting for 6 months or more. There's the duration. And it causes clinically significant distress in school, occupation, and other areas of functioning. And then it is not better explained by the symptoms of another mental disorder, including fear, anxiety, and avoidance of situations associated with panic-like symptoms or other incapacitating symptoms, as in agoraphobia. Objects or situations related to obsessions, as in obsessive-compulsive disorder. Reminders of traumatic events, as in PTSD. Or separation from home and attachment figures, as in separation anxiety disorders. Or social situations, as in social anxiety disorder. So that sounds really confusing, but I'll show you in the next slide. Specific phobias are very, very specific. So the DSM-5 lists 5 subtypes of specific phobias. So there's the animals subtype, so that's being afraid of spiders, insects, worms, snakes, dogs, cats, rodents, frogs, birds, fish, any animal that somebody could be afraid of. The natural environment might look like someone that is afraid of heights or water, storms, wind, darkness. There's even a few reported cases of people that are afraid of the sunshine. Blood injection and injury, sometimes called BII. So these are people that are afraid of seeing blood or injections, surgery, blood tests. This is like if you were to go to the doctor to get a blood test. Typically, you might faint, which we're going to talk about. There's a very specific reaction in your body that is associated with that, and we're going to talk about that in class this week. And then situational, so elevators, airplanes, enclosed spaces, and then other could be things like choking or vomiting in children, loud noises, costume characters, That would be other. There's mixed evidence for the validity of these subtypes. Some data suggests that these fears and phobias might lump together, but then subsequent data hasn't supported that as much. The blood injection and injury phobias tend to cluster together. There's debate about whether the division is meaningful. Is the fear of the dark natural environment or situational? So sometimes the fears that are presented, there's some debate as what subtype that they go into. It's probably the most useful just to label them by the specific target of the phobia. And it is very common for people to have multiple specific phobias. So the average individual with specific phobia fears 3 objects or situations, and approximately 75% of individuals with specific phobia fear more than one situation or object. And when you are coding this, you can diagnose them with more than one in that case. Here's the epidemiology of specific phobia. So the prevalence rate is 7% to 9%. However, rates are generally lower in Asian, African, and Latin American countries. So why do you think that is? Maybe take a moment to kind of jot that down. Why do you think that the prevalence rates are lower in Asian, African, and Latin American countries? 2 to 4%. So the prevalence rate in children is 5% and 16% in 13 to 17-year-olds. So that is a huge jump. It's almost 3 times as large in 13 to 17-year-olds. So why do you think that is? Maybe take a second and write down some assumptions or hypotheses you have about that as well. There's a 2 to 1 ratio, female to male, and the age of onset is typically prior to 10 years old. And then child onset phobias often disappear by adolescence, but those that continue tend to be chronic. So if you have that fear of spiders as a child, the phobia of spiders, not just a fear of spiders, and it's not gone by adolescence, typically you'll have that for most of your life. So social anxiety disorder, the DSM-5 diagnostic criteria, marked fear or anxiety about one or more social situations in which the individual is exposed to possible scrutiny by others. Examples include social interactions, being observed, and performing in front of others. So this is really important because not only is the person afraid to kind of, like say for public speaking, not only is the person afraid to stand up there and speak because they're in public, it's because they fear being evaluated negatively by others. And they fear that because they think that they will act in a way that shows their anxiety symptoms, and that will be negatively evaluated by others. So I'm afraid of public speaking. I'm going to stand up there. My heart's going to start beating. I'm going to start sweating. People are going to be able to see that. They're going to know that I'm afraid, and then they're going to think that I do a bad job. The social situations almost always provoke fear or anxiety, and they are avoided or endured with intense fear and anxiety. So thinking of public speaking, just because it's a very common one, people typically who have that phobia might totally avoid public speaking altogether, or jobs that entail public speaking. The fear of anxiety is out of proportion to the actual threat posed by the social situation and to the socio-cultural context. So within public speaking, there probably isn't that big of a threat that something is going to happen, but the anxiety around it is so large, the perceived anxiety around it is so large that the person just can't get themselves up there to do it. The anxiety and avoidance is persistent, typically lasting for 6 months or more. It causes clinically significant distress or impairment in school, occupational, or other areas of functioning. Again, thinking about public speaking, that would have definitely a detrimental effect in school when you have to give presentations, or in your job when you have to even talk at meetings. Sometimes people aren't even able to do that. The fear, anxiety, or avoidance is not attributable to the physiological effects of a substance. So making sure that your client is not taking any substances. It's not better explained by the symptoms of another mental disorder, such as panic disorder, which we're going to talk about in a couple minutes, body dysmorphic disorders, so it's not because you hate the way that you look, or autism spectrum disorder again. And if another medical condition is present, the fear, anxiety of avoidance is clearly unrelated or is excessive. And the DSM-5 would cause you to specify if this is for performance only. So social anxiety disorder for getting up and public speaking would be performance only, as opposed to social anxiety disorder where the person won't go out with their friends or won't go out like to a bar or out to dinner because they're afraid they're going to be evaluated all the time. That would not be performance only. So the epidemiology of social anxiety disorder, the lifetime prevalence is 12.1%, which is a pretty large number. So this definitely affects, will probably affect a lot of the clients that you see. The 1-year prevalence rate is 6.8%. The median onset age is 13 to 20 years old, but it's often preceded by long-standing shyness. It's more common in women in community samples, but more common in men in clinical samples, which is really, really interesting. And I'd like you to take another moment and kind of write down why you think that that is. And then there's a higher prevalence rate in American Indians and lower in persons of Asian, Latino, African American, and Afro-Caribbean descent as compared to non-Hispanic white individuals. So we're kind of seeing a trend with the anxiety disorders in terms of their prevalence rate in different ethnicities. And I'm wondering why you think that is as well. It's kind of the same question as before, but what do you think's going on there? And I hope that you like my cartoon, the blowfish with social anxiety disorder. If you can't read it, it says, "Don't puff up like an idiot. Don't puff up like an idiot." But he's a blowfish. It's really funny. And then chronic and lifelong phobias. So typically, if you have social anxiety disorder, it's chronic and lifelong. So comorbidity. So if you can remember what comorbidity means, it means what other disorders might go along with social anxiety disorder. So 56.9% of people have another anxiety disorder. Again, that's over half. That's a huge number. 1/3 of those with current social anxiety disorders report depression at some point in their lives. And then there's a high correlation with substance abuse disorders. So most of the research has been done on alcohol use disorders. So 13% have a 12-month comorbidity with alcohol use disorders. Nicotine dependence is 2 to 3 times higher among those with social anxiety disorder. And then cannabis dependence is 29% lifetime among people with social anxiety disorder. And there is, I think that's Rapunzel. Because of my social anxiety disorder, I feel connected to Rapunzel. I hope that one day my life will begin. Social anxiety disorder, it's very debilitating. Typically clients, they want to be able to do the things that they can't do because they feel so anxious. So it definitely is something where mental health counselors can help a lot in terms of treatment. Interpersonal factors in social anxiety disorder, and this comes from a number of different sources which are on the bottom of your screen, but it's associated with impediment in the development of close relationships. So people with social anxiety disorder tend to have fewer friendships and romantic relationships and a lower likelihood of marriage just because they're not putting themselves out there. They're too afraid to do that. Peer victimization, and then difficulties with self-disclosure. So they're always afraid that they're going to be evaluated or judged. So they're not going to readily disclose things about themselves that might get evaluated or judged by others. Also, possible destruction to existing close relationships. So they tend to have negative interpersonal styles of relating to each other. Lower quality relationships, because if you're always hypervigilant around being evaluated by people negatively, you're probably never able to be yourself, and therefore your relationships suffer. Interpersonal dependency on others. What happens a lot of the time with people with social anxiety disorders is that they are constantly seeking reassurance. And, did I do a good job? Do you think people like me? And they can become dependent on their friends to kind of give them that reassurance to make sure that the evaluations that they're receiving from people are in a positive light. And sometimes that can be annoying to constantly have to reaffirm to somebody that they were great all the time. So sometimes that can also affect their quality of relationships. And then more negative communication patterns in romantic relationships. So, panic attacks. Here is what happens when someone has a panic attack. So a panic attack is an abrupt surge of intense fear or discomfort that reaches a peak within minutes and includes 4 more of the following symptoms. So your heart is racing, you start sweating, you're shaking, you're trembling, you might have shortness of breath, you might feel like you can't breathe, somebody's choking you, you might have some chest pain, you might all of a sudden feel like you're going to throw up, you might be dizzy, you might actually faint, get chills or heat. You might get some numbness and tingling in your body. You might have a derealization or depersonalization, so you feel like you're kind of stepping outside of your body and watching what's happening. And then you have this overwhelming fear of, I am losing control. Oh my God, I am going crazy. And oh my God, I am going to die right at this minute. And if you look on page 214 of the DSM, these panic attack specifiers are, that's where they're located on page 214 of the DSM. Panic attacks are very, very scary. I have a lot of clients that present with panic attacks, and they say that the scariest part of it is that it comes out of nowhere, that there's typically not an event that triggers them into a panic attack, because if there was, then we could do a lot of treatment around being able to control for that event. Attacks lead to panic disorder. So the diagnostic criteria for panic disorder is a recurrent, unexpected panic attacks, and at least one of the attacks has been followed by 1 month or more of one or both of the following. So persistent concern or worry about additional panic attacks and their consequences. So here I am, I'm having a great day. All of a sudden I have this panic attack out of nowhere. I think I'm going to die. The panic attack subsides. I'm like, what the heck just happened to me? And then all of a sudden my thought process is, oh my God, when is that going to happen again? Wonder if that happens again. Wonder if it happens when I'm at work. Wonder if it happens when I'm, at school. Wonder if it happens when I'm with my kids. What am I going to do? And then, as your thoughts start swirling in your head, then you feel like, am I going crazy? A significant maladaptive change in behavior related to the attacks. So I am so afraid that this panic attack is going to happen again at work that I'm not going to go to work anymore. Or I had a panic attack at church, and oh my God, wonder if I have another panic attack at church, I'm going to avoid going there. That's my maladaptive change in behavior. The disturbance is not attributable to the psychological effects of a substance or another medical condition, and is not better explained by another mental disorder. And I apologize for all the typos on this slide. There's a lot of typos. The epidemiology of panic attacks. So the prevalence rate is 2 to 3% of adults and adolescents. Again, keeping in trend with all the anxiety disorders, lower rates reported among Latinos, African Americans, Caribbean Blacks, and Asian Americans. And then lower estimates for Asian, African, and Latin American countries, 0.1% to 0.8%. That is way lower than the U.S., 2 to 3% of adults and adolescents. There's a 2 to 1 female to male ratio. The median age of onset is 20 to 24 years old. That's when people typically experience their first panic attack. There's a gradual increase during adolescence, particularly in females following the onset of puberty. And I get that a lot in the adolescents that I see. Typically, a lot of them present with panic attacks after they get their periods. And then the prevalent rates decline in older individuals. So 2 to 3% of adults and adolescents, and then it declines to 0.7% in adults over 64. And I love some e-cards. I thought that one was really funny. My growing anxiety over the increasing frequency of my anxiety attacks is causing me to have constant panic attacks. So like I said before, agoraphobia translates to fear of the marketplace. So here's the DSM-5 diagnostic criteria for agoraphobia. So marked fear or anxiety about two or more of the following: using public transportation, being in open spaces, being in enclosed spaces, standing in line or being in a crowd, and being outside of the home alone. So as you can imagine, agoraphobia is extremely debilitating for clients. Typically, clients won't even come to you for treatment because they're afraid of leaving their home. So lots of times when you're working with someone with agoraphobia, depending on what agency you're working for, or even in private practice, sometimes home-based therapy might be really helpful. The individual fears or avoids these situations because of thoughts that escape might be difficult, or help might not be available if panic-like symptoms or other incapacitating, embarrassing symptoms develop. So wonder if I am outside my house and I have a panic attack and there's nobody there to help me. Or wonder if I am outside my house and, it kind of speaks to that social anxiety piece too. So if I am standing up in front of all of these people and all of a sudden I start getting all of these panic attack symptoms or anxiety-like symptoms, and there's nobody to help me, what am I going to do? So I'm not even going to go. Agoraphobic situations almost always provoke fear and anxiety. So even thinking about leaving provokes the fear. You don't even have to actually leave the house. The thought process is provoking the fear and anxiety as well. The situations are actively avoided, require the presence of a companion, or are endured with intense fear or anxiety. So I'm not going at all. Or I'm going to go, but I can only go if my spouse comes with me, or my mom comes with me, or my dad comes with me. I'm going to go, but it's going to be terrible because I have such intense anxiety while I'm there. And the anxiety is out of proportion to the actual danger. So typically when you leave your house, nothing terrible is going to happen to you, hopefully. So just the thought of that would be out of proportion with the actual danger that might occur. The fear, anxiety, or avoidance is persistent. It lasts for 6 months or more. And as we said, this is significantly debilitating to social, occupational, and other important areas of functioning. If another medical condition is present, the fear, anxiety, or avoidance is clearly excessive, and it is not better explained by the symptoms of another medical or mental disorder. The epidemiology of agoraphobia, the 12-month prevalence rate is 1.7%. It's twice as common among women. Employment status is a strong predictor. So if you are unemployed and feel like you don't have a purpose to go to every single day, then that is a strong predictor of having agoraphobia. The typical onset is in the late 20s, and the majority report early onset of panic disorder or panic attacks. So panic disorder and panic attacks come first, and then I don't want to leave my house because wonder if I have another panic attack. But significant minority and community samples report no panic-like symptoms or precedence of agoraphobia. The 12-year recovery rate is worse when agoraphobia is present. So the 80% for panic without agoraphobia and only 48% with agoraphobia. It's a big difference. It's almost twice as much. And then the last one we're going to look at is generalized anxiety disorder. It's very commonly called GAD or GAD. This is excessive anxiety and worry occurring more days than not for at least 6 months about a number of events and activities. So it's not only because my attachment figure is going to leave me, and only because I'm afraid of spiders or blood or clowns, or only because I don't want to leave my house. It's everything. I'm worried about everything all of the time, more days than not. The individual finds it difficult to control the worries, so the thoughts just run through your head. The anxiety and worry are associated with 3 or more of the following 6 symptoms. And at least some of the symptoms have to be present for more days than not for the past 6 months. So the sense of restlessness or feeling keyed up or feeling on edge, that's that kind of hypervigilance feeling. Being easily fatigued because it's exhausting that your body is always operating in this sense of fear, this fight or flight all of the time. difficulty concentrating, or on the total opposite end of it, your mind just going blank, irritability, muscle tension, and sleep disturbance. So for anxiety, if a client presents with anxiety, it's a good idea to ask about sleep patterns, just like we did for depression. The anxiety, worry, or physical symptoms cause clinically significant distress in school, occupation, or other important areas of functioning. It's not attributable to the psychological effects of a substance, and it's not better explained by another mental disorder. Epidemiology of GAD, 0.9% in adolescents and 2.9% in adults. So it jumps almost 2% from the time you go from adolescent to adult. The lifetime risk of acquiring this and having this is 9%. That's also pretty high. I think a lot of people have generalized anxiety disorder. I definitely have generalized anxiety disorder, and we'll talk about that in class. But this is a really common one. Prevalence peaks in middle age and declines across the later years of life. It's almost twice as common among women. Individuals of European descent tend to experience GAD more frequently, which I thought was interesting. And it's more common in individuals from developed countries. Why do you think that this is? Why do you think that GAD is more common in individuals from developed countries? Take a second to write that down. And then comorbidity. So comorbidity with generalized anxiety disorder is huge. One estimate is that 90% have another anxiety or a mood disorder. And there's lots of comorbidity with other anxiety disorders. 41% with panic, 42% with social phobia. So odds are if you have generalized anxiety disorder, you probably have another form of anxiety disorder as well. So there are lots of treatments. Typically, CBT is kind of the number one go-to treatment for anxiety, but depending on what form of anxiety you have, if you have separation, or if you have specific phobia, or if you have GAD, treatments are going to differ a little. So instead of doing that in the PowerPoint, we are going to do that in class. There's also a lot of alternative forms of treatment for anxiety, which is my little yoga girl right there. So we will talk about those as well. So I asked you to answer a couple questions, and those I will post up in the reminders section of this. Make sure to read the DSM section on anxiety. It is a little long just because there are a lot of disorders, but it's definitely important to be able to distinguish between them. So read that. Read the anxiety chapter in your textbook. And then we will talk about it in class. And then I also will be putting the beginning section of the review for the midterm in that link on Blackboard. So check in there, and you can start looking over things for the midterm as well. So I will see you this week.